Good afternoon, everyone, and welcome to our session today with Dr. Martin Kolb and Dr. Kieran Scott. Dr. Martin Kolb is the Moran Campbell Chair and Professor in Respirology Medicine and Director of the Division of Respirology, McMaster University in Hamilton, Ontario, Canada. His major research interests are fibrotic lung disease with a particular interest in the role of growth factors and matrix abnormalities in disease progression. He leads activities in biomarker development for lung fibrosis and is the principal investigator and steering committee member in numerous ILD clinical trials. Dr. Kolb has authored over 130 peer-reviewed publications on different basic science and clinical topics. He's the chief editor of the European Respiratory Journal from 2018 to 2023. He is also an editor board member of American Journal of Respirology and Critical Care Medicine, American Journal of Respirology Cell and Molecular Biology, the European Respirology Review in Respirology, and serves on the Lung Injury and Repair Study section for the National Institute of Health. Dr. Kolb is also a medical advisory member of the Canadian Pulmonary Fibrosis Foundation. Dr. Kolb.
Hello. Do you hear me, Sharon?
Yes.
Perfect. So it's a pleasure to be here and provide some education. And thanks to the CPFF for stepping up once again to do something important. We know that in pulmonary fibrosis, there is a lot of need for education, which is not only true for healthcare practitioners, doctors. It is true for allied health professionals, RTs, nurses, psychologists, and it is of course also true for the immediate caregivers for the patients and the patients themselves. So I assume that the audience here is a pretty broad spectrum that covers all these groups, and I try to be as simple as I can. Forgive me if sometimes we thrive away into medical jargon, but it is a medical condition and we have ample time afterwards to talk about questions. So what I choose to talk about today is called progressive fibrosing interstitial lung disease. And this means it is not only IPF that I'm talking about, but other types of lung fibrosis as well. I have some disclosures. You already mentioned some of my potential conflicts. And of course, I have been working with pharmaceutical industry, amongst others, to develop drugs that are currently on the market. And there are many other compounds in the pipeline of becoming tested, and all of these activities will hopefully result in improving the care for patients with pulmonary fibrosis. Now, let's start with a patient perspective. So there are some international surveys of patients and pulmonologists, and these surveys highlight just the need for more knowledge. So when you ask patients, about less than 60% recall of hearing that IPF is a progressive disease. Less than half are informed about treatment at the first visit. It's obvious that pulmonologists often are more concerned about side effects than about the effects of a disease and the progression. And in principle, patients wanted more information about the disease, about prognosis, and about the pharmacological treatment. Now, that of course tells us as experts in the field that we need to continue training the people who provide care for patients with pulmonary fibrosis, and that includes everyone from the patient to the pulmonologist that takes care of them. Yeah, but it is very important in a disease like this to know what you are potentially facing and to also make aware that some of the progression elements are not predictable. Now, the physician, of course, should always mention that these disorders have a tendency to progress. I always say this is not affecting everybody, and we cannot predict at the beginning where someone's journey will go. But as a statistical means, they progress, these patients. And yes, a statistical mean means a lot for a doctor who cares for patients. It does not mean anything for the individual. So you have to interpret this knowledge in the proper context. And for me, it's also important that I want my patients to be a partner in the decision-making process. So whether or not we start treatment with anti-fibrotics or other drugs should always be a joint decision of the doctor and the patient at stake. Now, some reasons why patients with IPF, for instance, do not receive treatment yet is that there is a perception that mild or presumably stable disease does not warrant therapy. I will show you some numbers that show that even mild disease is progressing, and stability is sometimes just something we try to cling on to, but it's not always given. There is, for many doctors, still a lack of confidence in the diagnosis of IPF and in other fibrotic lung disease. There are questions about access and, of course, the cost of the medicine, and concerns about the side effects of the therapy. And if you ask pulmonologists, why would you not treat patients with anti-fibrotics despite them being approved, you get a lot of different responses here, but they vary a lot. So older people don't necessarily tolerate these drugs as well because they have other health concerns that makes them less tolerable. Stability already alluded to, the unclear lung function, the unclear diagnosis, confidence, the good quality of life that you may not want to interfere with by giving drugs that could reduce quality of life. So there are a number of questions, but in my practice, we always address these questions with each patient and then make a joint decision. But I think it should be always discussed and offered at least. Now, we just had the European Respiratory Society meeting. It was a virtual congress, but there were some posters shown and projects described that are around patient questions and concerns, and the patient journey for patients with IPF, which was studied in four countries here, France, Germany, Japan, and US. It still shows that the delay in diagnosis from symptom onset to making a diagnosis of IPF still goes up to 2 years, yeah, which is a little bit better than historical studies, but it's still a long time to diagnose a disease that's been progressive in this time span of 2 years. And also the meantime from making a diagnosis to starting anti-fibrotic drugs is up to a year in Japan here. So there are areas where we have to become better. And just another element of this poster that was shown on the right side here, and this is more for the healthcare providers in this audience here, is that it is still a common thing to misdiagnose IPF for a long time with other conditions that could cause shortness of breath, such as COPD and congestive heart failure or asthma. So there is still a lot of wrong diagnoses, and involving expert centers would certainly help these patients. Now, this was something that is coming right from the patient's perspective. I want to switch a little bit now to a didactic element and talk about interstitial lung disease, talk about the diagnosis, and talk about the management. Now, interstitial lung disease is a big group of disorders, And not all of them are fibrotic. Yes, so some are non-fibrotic, they come and go. Others are fibrotic, they leave scars, but they are not doing anything bad after being there. And there are disorders that are progressively fibrotic, and the prototype of this disorder is IPF. A lot of the knowledge that we have in our books is, of course, based on science, and that is involving statistics. And in real life, sometimes the management and the approach is a little bit different, but the guidelines and the knowledge we create is certainly helping us to make the best decisions for our patients. Interstitial lung disease encompasses way more than 100 different entities. And what we teach our trainees in our training programs is to make as good a distinction between those disorders as you can, because they typically would lead to different management strategies. Yeah? So we would counsel the patient differently, we would use different drugs, we would make different prognostic assumptions. So it's very important to figure out which ones of these disorders a patient has. IPF is amongst these disorders the worst, if you want, because it's a reasonably large group. It's about a quarter of the patients we see in an ILD clinic. Its prevalence is increasing. It affects more the elderly folks. So someone with IPF at age 45 or 50 would in our clinic usually be the baby. Typically, those are people who are 60 to 70 years and older. The cause is unknown. There are known risk factors that include genetics, environmental exposure such as cigarette smoke and others, potentially viruses and reflux. But it's unknown, and when a disease is unknown and it's there, we use often in medicine the term idiopathic, which just pays tribute to the fact we don't know the exact cause, but we know a lot about its behavior and how we can change its behavior. Now, in the elderly population, this disease is rather common. It is indeed much more common than asthma in this population who is above 65 years. And it shows that this disease is essentially a disease of aging. And aging biology means that the body own repair system is just getting older and exhausted, and when it cannot repair damage in a good way anymore, it just builds up scars, and that is more or less the same word for fibrosis. Now, the sad news is that IPF as a disease is comparable to many cancers that people know much more about. And if you look here at the 10 most common cancers that affect humans in the industrialized countries at least, and you put the 5-year survival side by side with IPF, you see that only pancreas cancer and lung cancer have a worse 5-year survival than IPF. And that hopefully changes with us using anti-fibrotic therapies, but it is a number that you can easily find if you just go to Dr. Google. And important it is always to put this in the right context. Yeah, so if a patient has a concern, you should always speak to your doctor, because this all has not the same meaning for an individual than for the large group of patients that we look after. We have learned a lot about IPF in the last 2 to 3 decades. Part of it was because of a lot of activities in the research labs, with understanding the biology of the disease. But a lot of it also is based on clinical trials over the 25 years. And you see here over a time scale, the number of clinical trials that were done until 3 years ago when this review was written. And the larger the bubble here, the bigger is the number of patients in these trials. So we learned a lot. We got a lot of data. We know about how IPF patients behave. And it is actually a curve that we want to flatten. similar to the COVID curve that we heard about for many months now. That curve is the decline of lung function over time. And we know quite well that a patient with IPF loses about 200 to 250 milliliter of the lung volume per year. A healthy subject at the same age would lose about 20 to 40 at most. So you see that when you have this disease, you lose about 10 times more lung function, or with other words, your lungs shrink 10 times more quickly than it would just by getting older. And if you just multiply that by years, you would then see if it's 200 per year, and you think about 5 years, in 5 years you have 1 liter less. If you are a smaller person and you start with 2.5 liters, in 5 years' time, you have just a bit over 1 liter left, which is a lung volume where life is hard to lead. Yeah, so this is pretty solid, that knowledge, and any intervention that makes the loss less large would be welcome. Indeed, the medications that we have approved reduce this loss to about half of it. So instead of losing 200, you lose just 100 on average, which is a big benefit, of course, for the patients. Yeah, those two drugs are called pirfenidone, trade name Esbriet, or nintedanib, trade name Ofev, and both have been shown to reduce that slope. Yeah? So this is a 12 months period in the clinical trials, and you see that the patients lose between 200 and 400 per year. And if you take placebo and if you take the medicines in these trials, you lose just about half of it. The time, one thing that these drugs also do is they cause exacerbations. And an exacerbation is an acute flare of the disease. There is often some inflammation going on. That's why we treat these flares with steroids. And these are often very critical episodes in the life of a patient with IPF. And they come, unfortunately, with a significant number of mortality. And if we can avoid these events or just postpone them to a later time point, of course, it would be benefiting the patients. And using anti-fibrotic drugs such as nintedanib in this example would help to postpone these events. Now, one question that comes always up is, how long is this effect preserved? And does it disappear after a year or 2 years of treatment? With other words, as a doctor, should I wait using these drugs until a patient is really bad and I may need them because they may lose their power? As far as we can say, that's not the case. As far as we can say, these drugs are continuously active if you take them. And this is a study that was up to 4 years. And you see that this worsening over time is not changing. It's about at a rate of 100 milliliter per year. As I mentioned before, without the medicine, these patients would have been twice as low after the 4 years that is surveyed here. One other question is, do we treat just a number, a breathing volume number, or do we improve lives and extend lives with this intervention? That has been an academic debate for quite a while, where some people argued that you only change a number, but you have not shown me that you improve lives, because the quality of life certainly is not improvable with a drug that causes diarrhea or nausea. And this data has been generated that clearly links the lung function loss with mortality. Yeah, so at a larger group, if you change that loss of lung function, you will extend life and you will improve survival in these patients. Yeah, so that's something very important for us to know and to take into account as well. And that's also been shown for the other drug, nintedanib. Yeah? So there's overwhelming support for the benefit of affecting that loss of lung function, or basically in simpler words, you reduce the speed of lung shrinking and you extend lives. We are fully aware that this comes at a cost, not only financially, but it comes also at a cost that a patient feels. And this will always be an important element when we talk about starting treatment with a patient, because a patient will possibly and likely feel some side effects. Could be appetite loss, could be nausea, could be fatigue, it could be skin rashes, which are much more common in pirfenidone treatment. And it could, as often happens with nintedanib treatment, lead to diarrhea. Yeah, but none of these side effects are dangerous as long as you stay hydrated. But it can be as bad enough so that a patient says, I prefer the original disease over the side effects of the drugs that I have to take for it. And some may also say, if this is the quality of life that I have, I don't want to live longer. Yeah, why would I extend my life when it's so miserable? Yeah, but I also, from pretty robust and experience with hundreds of patients on anti-fibrotic drugs, the large majority of patients tolerate these drugs quite well, and they have no problem long-term with the side effects. Yeah, so in real life is no different than in clinical trials. Yeah, so we have not seen any high numbers of serious side effects that would be life-threatening. Now, as I said, all this knowledge comes from IPF, and IPF is a disease that we studied most in the past. Now, the last few years have really been also years where we put other types of lung fibrosis into focus. Indeed, in our clinics, the specialty clinics for ILD, we see many other disorders, and IPF is about a quarter, and we see a lot of diseases called hypersensitivity pneumonitis or autoimmune disease in the context of rheumatoid arthritis or myositis or scleroderma. We have a group that is unclassifiable, and we have, of course, other diseases like sarcoidosis or asbestosis. So on the left side is a review article that was published in the New England Journal. On the right side is unpublished data that we have from our own Canadian landscape and the ILD centers there. And we see pretty much the same distribution. And by focusing on patients with IPF for many years, we have somewhat neglected the people who have other disorders. And this has changed in the last year. This is really that disease that we now call progressive fibrosing interstitial lung disease. Fundamentally, those are disorders that are not IPF, but behave like IPF. And our question was, if IPF is treatable with anti-fibrosis drugs, would these progressive fibrosing ILDs also respond to these drugs? Academically, that has led to a very important debate. And that is something, if you follow the academic debate more closely, will be with us for a while. And I just use this lumping versus splitting analogy here. Yeah, so splitting means we are splitting our diseases in different disease boxes. They have different names, and we can do that in a more detailed way nowadays because we can include blood tests, we can include genetics, you can get your genome tested, as you know, with tests that are advertised on the television. They're called 23andMe, where you can look at your ancestry, and you can also look at your genes that predispose you to certain diseases. This is something that I find personally relatively dangerous because these tests are not made for large scale, but it's also something that will come in the future. Now, if you split into the different diseases that we know, this is what we teach our trainees. We follow in the clinics a diagnostic algorithm to establish a diagnosis of a specific ILD. In Canada, we have this document here that is a good guidance document for doctors, which basically gives advice on what to do, what kinds of tests to do, and what may not be necessary. Fundamentally, we want to know whether a patient should be treated with anti-fibrosis medication, such as here in the middle, with immunosuppressive medication, which we typically use for autoimmune disease on the right, or if we should investigate whether a type of allergen causes the problem, like in hypersensitivity pneumonitis, and also treat with immunosuppression. So this is really a lot of work to find out which path of these three a patient goes, and they have all distinct treatment approaches. Now, one important thing that we look at is a picture. So we need these CT scans that are in high resolution, so very fine cuts through the chest, and then we look at patterns. So we look at changes that look like fibrosis or inflammation in the pictures, and you see here something that we call as typical usual interstitial pneumonia. It's a picture that is quite suggestive for IPF, and you see these thick lines at the outside of the lungs with the honeycombing lesions that look like a honeycomb, a beehive, and they are in the outside of the lungs. So these things make the lungs shrink. This is why the breathing volume goes down and why a patient cannot breathe at exertion. There are more patterns that we look at. So if it's a bit more subtle, without the honeycombs, we say this is a probable pattern. And we see pictures like this, where the lines are sort of all over. They are not only in the outside, they're also at the inside of the lungs. They are around the ear tubes and not just under the surface. They are a little bit clustered. And then this might be a picture where your doctor may say a biopsy would be useful to really find out what that is, because it could be 10 different things. And then we have pictures like this where we are pretty confident from the image only that this is not IPF. Yeah, so this would be here now a disease that would be hypersensitivity pneumonitis, yeah, where the pictures are. So, but that's what the doctors would do in a clinic, and the radiologist. We look at patterns, which we then combine with the story of a patient in order to come up with a diagnosis and then provide best advice about what to do with it. Now, life is never easy in this field. And one thing I always tell my patients at the beginning of a journey, I say, allow me to change my mind over time. Not because I'm too stupid to figure it out, but of course, time gives you more and more clues. And in many of these conditions, particularly when it's autoimmunity involved, we involve rheumatology. So a rheumatologist is a good, important partner. Not so much in IPF, but all all the other diseases. And this is my rheumatology colleague here, Dr. Khalidi, and those are two patients that I have seen in my clinic. I just want to illustrate that. So Gerald is the husband here. He had shortness of breath on exertion. He has a dry cough. He had some aches in his fingers. He had crackles over the lungs. His skin was pretty dry. He worked in a steel factory and was an ex-smoker who has quit many years ago, but he had some exposure to cigarettes, and his blood tests were normal. And the picture of his lungs showed these lines at the outside of the lungs with a few big cysts, and he was diagnosed with IPF and was treated with one of these fibrosis drugs. Now his wife, who I've seen before, she had a very similar story. She also complained about breathlessness on exertion and some cough. She had no aches, and she had the same kind of crackly sounds over her lungs. She had a dry mouth, no dry eyes. She was a never smoker. And the blood tests that you see at the bottom here are a bit abnormal. So they point towards autoimmunity. Her CT scan was not that different from her husband's. There was some subtle abnormalities that would point to a different disease. You see there are some areas with a light grayish touch. Yeah, this would be here. This is what the doctor would call ground glass opacity. And that made us, together with the sign of dry mouth, do a biopsy of her lips to look at the salivary glands. And this led to a diagnosis of autoimmune disease, specifically Sjögren's syndrome, which can cause fibrosis in the lungs. So very similar picture, very similar set of complaints, but very different disorders that are underlying. And of course, the one you treat with anti-scarring medication, the other you treat with anti-immune medication. Yeah, so, and that's something which makes our job a little bit more difficult because many different disorders can look the same. And we only work with the clues we get at the given time. The more clues we get, the better our job is, and the better we are confident about doing the right things. Now, back to my metaphor for the lumping and splitting. If you look at this tree of dinosaurs, you would probably agree that it makes sense to split them like this here. Just give you a few seconds to think why, because you will see on the left side are the big plant-eating dinosaurs. Right beside them are very big flesh-eating dinosaurs. And then there are smaller dinosaurs that eat everything. And there are other plant-eating dinosaurs. So this, to split them into these makes a ton of sense. What happens if you split disorders in medicine? You can create silos. In the context of pulmonary fibrosis, by focusing only on IPF for a long time, for a good reason, because that was the best defined disorder, we have been able to develop drugs and approved drugs that help you when you have IPF. But if you have a different disorder that behaves like IPF, but is based on an autoimmune disease, you're outside of the door. So you are not in this box that would have access to treatments. And that's been a problem for a good number of patients. I would think it's about another quarter of the patients we see in our clinic. So it's a very significant number of patients. If we say we put them all together and treat them the same way, we do not mean to lump them like this, because that's been the case 25 or 30 years ago, when anyone with interstitial lung disease was basically in a bad situation because nothing could be done. We gave them all steroids, which helps a small group of patients, but harms a bigger group of patients. So this is not anything we want. What you want by lumping is to do a reasonably rational way of lumping. I bring you back to my dinosaurs here, and I circle the carnivores. These carnivores are vicious beasts, or were vicious beasts. And while probably everyone knows Tyrannosaurus Rex and Velociraptor because of Hollywood, you would probably not know all these other types of flesh-eating dinosaurs. And you can split them into names that you will never be able to pronounce. If you encounter one of these dinosaurs from that group, you end up in the same way because you are eaten. In lung fibrosis, if you have a disease where fibrosis drives your progression and makes your lungs shrink, and shrinking lungs come with increased mortality, you will die of fibrosis, regardless of what started it. And that's really the concept of progressive fibrosing interstitial lung disease. It looks at the biology that drives the problem, which is for many at a particular stage of their disease, fibrosis. IPF is the prototype here. There is scarring from the start to the end. In autoimmune disease, there may be inflammation at the beginning, but then it's taken over by scarring. In hypersensitivity pneumonitis, it may be inflammation at the beginning, there is certain exposure, but it may end up with fibrosis. And this is why this concept is so important of the progressive fibrosing interstitial lung disease. A lot of these disorders that I showed you before, and I said there are way over 100, a lot of these disorders can end in fibrosis. And I have circled them all in red here. Yeah, so a lot of disorders that are not IPF can behave like IPF. Now, the question was, would the drugs that we now use very successfully for IPF also be useful for patients who have fibrosis but not IPF? Simple answer is, from a biology perspective, they should be working, because there is nothing specific about the fibrosis that drives IPF progression or that drives progression of autoimmune fibrotic lung disease. It's always excessive stimulation of scar-forming cells called fibroblasts and myofibroblasts. They make matrix, see at the right bottom, excessive ECM secretion, so extracellular matrix. It's basically collagen and fibers. They cause increasing stiffness of the lungs. If the lungs are stiffer, you cannot take as deep a breath, you feel breathless, and we measure lower lung volumes. Yeah, so, and this is where anti-fibrotic drugs would interfere. They would slow down these cells that make scar tissue. A patient would typically not feel if they have IPF or progressive fibrotic interstitial lung disease. The symptoms are the same: breathless at exertion, breathless at rest, and requirement of oxygen. Quality of life is decreased because you cannot do what you liked to do. Physical function overall is decreased because you cannot walk as long. In the CT pictures, we see scarring, and we have also these episodes of acute exacerbation. Scleroderma is one of these disorders that are best known amongst this group. It's a disorder that makes the lungs shrink. So scarring occurs in the skin and in the lungs. And we have a little bit of different picture in the CT scan. You see these areas of lines and haziness are not immediately outside. They are more inside of the lungs. This would be a typical picture for scleroderma. And we know that the occurrence of fibrosis in patients with scleroderma is a major cause for death in patients with scleroderma. So that's a disorder that is behaving like IPF, but it's not treatable until a short while ago like IPF. So we have a year ago published a study that looked at patients with scleroderma and lung fibrosis, and they tested if nintedanib helps them to slow down their lung function loss. And very similar to IPF, it did. So just look at the right side. Remember what I said, you want to flatten the curve. And you see that the curve that takes her down at about 100 milliliter lung volumes per year in these patients is flattened significantly if you treat them with anti-fibrosis medication. That drug has now been approved for treatment of these patients in most countries in the world, certainly in the US and in Canada and in Europe. I just skipped that one. Another disorder is rheumatoid arthritis. That's rather common. So you probably know, every one of the people in the audience will know someone who has arthritis. And rheumatoid arthritis is an autoimmune disease. It's different to the arthritis that is just driven by wear and tear by getting older. But it is a disorder that can cause debilitating shrinking and swelling of joints. And it can affect the lungs as well. And it can affect the lungs very similarly to what IPF is. And you see again these things that look like honeycombs. You see the lines at the outside of the lung tissue, and it can actually behave exactly the same way. Yeah, so if you look at patients with rheumatoid arthritis who have this picture that looks like IPF, the blue curves here, they behave like IPF. So if you overlay that with IPF survival curves, it's exactly the same. If you have arthritis with a different pattern, they're doing much better, but you still have an increased risk of mortality. Yeah, so having arthritis that affects the lungs is not good because you have fibrosis, and fibrosis drives progression, makes the lungs shrink, and makes mortality go up. Hypersensitivity pneumonitis is a disorder that is driven by allergies, not the typical runny nose, itchy eyes kind of allergy that is seasonal. It's a different type of allergy, and it is in response to things that are typically inhaled. And they can cause some inflammation in the lungs, some shrinking, and that shrinking can take over. And that when the shrinking takes over, it is fibrosis, and fibrosis progressives. And that is then leading to the same thing I said a few times before about other disorders. About a year ago, we published a trial that addressed this clinical need. And that was called the inbuilt trial. So this was a trial that looked at these patients that I just described, and it looked at the drug nintedanib. These trials are usually done in a way that is called randomized double-blind. It means patients who enter the trial are randomly assigned to either the drug or the placebo. They are followed for, in this trial, 2 years or longer. And double-blind means that neither the patient nor the treating doctor would know what the patient takes. That's the best way to test new medicines, for the reason that no one should know what they take, because everyone who takes a new drug and has a disease that is serious wants this new drug to work. Yeah, so you take that factor out by making it double blind. Yeah, so only at the end of the treatment, everyone will know what they were on. And that's the only way how we can test if a new drug is working for a condition or not. Now, back to the slopes and the curves. You see two things in this curve. The placebo is the light blue. The nintedanib or OFEV group is the dark blue. And you see, for one, that patients who have lung fibrosis, other than IPF, lose about 200 milliliter lung volume per year, very similar to IPF. So they have no IPF, but they behave like IPF. And if you treat them with anti-fibrosis medication, you reduce that loss to about half. Again, an effect that is extremely similar and comparable to what we've seen in IPF patients. The side effects in this patient group is also the same. You see that diarrhea is a common problem. About 2 out of 3 patients will have episodes of diarrhea. There is some nausea involved, but no dangerous side effects overall. And that's the same thing as we've seen in IPF. Now, this was a lumping approach. So the trial included all these other patients. They had autoimmune disease, they had unclassifiable disease, they had hypersensitivity pneumonitis. And if the reason why it was put together in this group was that none of these pieces of the pie alone would have sufficient numbers of patients to make a trial meaningful enough. That's why it was put all together into one. But obviously, the question of a regulator and or a doctor would be, is one of these pieces of the pie driving the signal? So is one of these groups responding particularly well or not at all to the therapy? And there are ways to test that. And you see here that none of these groups would be an outlier. If you, the way how you read one graph of this is the zero line is the middle, and anything to the right of the zero line would favor the drug intervention. If something is on the left of the zero line, it would favor the placebo group. So it would say that the placebo group is doing better than the drug group. Of course, that's not good for a drug then, but you see that all these lines are way to the right. Yeah, so it means that all these disorders respond in the same way. And this is not surprising because all these disorders at the stage of the patients that were enrolled in this study were driven by scarring. Pirfenidone is another drug that was tested in a similar context. It was just in a group called unclassifiable, but fundamentally this trial showed the same thing. It was not as robustly shown for pirfenidone than for nintedanib, but it gives the same message. It basically says that when you have fibrosis driving the progression of the problem, anti-fibrosis medications are helpful. Now, coming to the end of what I want to talk about and giving you a chance to ask questions, we have with all types of lung fibrosis, regardless of what it is, some exposure, some inflammation, and some fibrosis. Now in IPF, we don't know what the exposure is. We learn a little bit about genetic predisposition. We know that 2 out of 3 patients with IPF have been smoking in their life, but other exposures we don't know. What we see in a patient with IPF from the first time we encounter them to the end is fibrosis driving the problem. So anti-fibrosis medications are the drugs that you would choose. In autoimmune disease, there is inflammation. Yes, anyone who had rheumatoid arthritis feels how angry a joint can get and how inflamed they are and how good steroids are for this condition. But at some point, scarring may take over. And when scarring makes the lungs shrink, you should use anti-scarring medication as well. If you have inflammation, you should use anti-inflammation medication. And in hypersensitivity pneumonitis, the bottom here is we in the clinics put a lot of effort and time on identifying what could cause it in order to give a patient good advice of what to avoid. If you can avoid it, your disease will usually stop getting worse. If you have inflammation going on, you need to treat with anti-inflammation drugs. If you have fibrosis going on, you need to treat with anti-fibrosis drugs. And some patients will possibly need all of this. You need to counsel and try to avoid triggers. You will need to treat with inflammation and fibrosis at the same time. So this is what I wanted to say. I hope that this didn't get too much into detail, but it is something important. And I will give it back to Sharon now, and she will moderate the questions that you have.
Thank you, Dr. Kolb. The first question that we have for you is, how far away are we for receiving funding for fibrotics in non-IPF patients in Canada?
Well, good question. So the process of getting drugs funded by the government or by insurance is usually taking a year, I would say. So what happens first is that Health Canada tests if a drug is, first of all, safe to give to patients, and is it working. That Health Canada approval has happened, I think, end of May this year. Once Health Canada says it's safe to give this drug and they work, there is a process in Canada called the Common Drug Review, which is a federal way to say, well, across Canada, we would think this is about the proper price and value for a drug. And then once this Common Drug Review has made a statement and recommendation, the different provinces will then finalize of what will be paid and which patients will get the drug. So this takes time, I think, up to a year. So we would not expect a final outcome before early next year. And it never goes quick enough for patients, of course. But it is a process that is in place, and private insurance is sometimes a little bit quicker, but that's sort of the timeline.
So Dr. Kolb, I just wanted to add to what you just said was that the Canadian Pulmonary Fibrosis Foundation has made the application to the Common Drug Review, CADIF, as is better known, to show support for this drug. And we are having a summarization of it. So hopefully it will go through shortly for that review, but we have done that. Now, because this is a drug that's already been approved for those with IPF, we're hoping that it'll be a shorter lag time for provinces to agree for payment, because the last province to come on board to pay for the drug OFEV was November 2018. And that's been 3 years in that process and trying to get it done.
Yep.
Okay, so our next question for you, Dr. Kolb, is that in the meantime, is there any other means of funding to cover medical costs in Canada for anti-fibrotic in non-IPF patients?
Well, it's the same line of questions. Unfortunately, no. So as I said, I understand that for patients it could never be speedy enough, but we have to acknowledge that the people who work in the ministry are this year particularly challenged with a lot of other health challenges that we have and a lot of other questions. So they're working, I think, at their best. It takes a while. We have plans to do a clinical trial in real life for this exact group of patients and across Canada. And this would give access at least to some patients who would qualify for that. But for the large group of people who have non-IPF type pulmonary fibrosis, it will still be, I think, another 6 months at least. As a little bit of reassurance, these disorders don't really, as bad as they are long-term, 6 months up or down are maybe not as critical. The importance is when you take these drugs is that you are on them for a long while. Yeah, so whether you start now or in 3 months or in 6 months is for me not as important as if you tolerate them and they do work, I want you to be on them for many years.
I just wanted to add to what Dr. Kolb had mentioned. If you go to the CPFF website, www.cpff.ca, we do have a section there that gives you links to the various governments and some of the programs that they might have to maybe fulfill a gap. I can only speak to Ontario because I know that best. There's the Ontario Trillium fund that will, on compassionate grounds and, you know, based on your qualifications, cover some of those medical costs. So if people are interested, they can go there and do that. It doesn't look like there's any more questions for you, Dr. Kolb. So I want to thank you so much for presenting today, and thank you very much for all the information you shared with us. It's been very helpful. I hope our audience enjoyed your session as well.
My pleasure.
Thank you. Our next presenter is Kieran Scallon, Dr. Kieran Scallon. He's a residency in internal medicine from the Case Western Reserve University. He is a residency in respirology at the McMaster University, and he's a fellow in lung transplant from the University of Toronto, and he's a fellow in interstitial lung disease with McMaster University and the University of Washington. And one of his mentors is Dr. Martin Kolb. He's the current assistant professor of medicine at McMaster University, and his research interests are health-related quality of life in ILD and the management of cough and ILD. Dr. Scallon.
Thanks very much, Sharon. It's really my honor and pleasure to be here today, so thanks so much for asking me to speak. I'm just going to try and share my screen here for the slides. Apologies. Let's see if we can. Is that working?
Yes, it is. Thank you.
Okay. Perfect. So again, thanks for the invitation to be here today. And I'd like to present on lung transplantation for interstitial lung disease. And I've tried to base what I'm speaking about today on my experience with speaking to many patients in clinic who have many questions about this process and its role in the management of interstitial lung disease. So I've tried to keep things very general, and I'd be very happy to field any questions that anyone might have after we finish. I will present some data, I think, to give us some context and a deeper understanding of why we make the decisions that we do, and also go over in a pragmatic way what to expect both before, during, and after the transplant process. So I have no relevant conflicts of interest to disclose. And as I said, the objectives for today, we'll go over some history of lung transplant, where things all started, and some of the innovations which have been developed recently and will have, I think, some implications on how the field moves forward. We'll review the selection of lung transplant candidates and how the assessment process works. What to expect during this evaluation, and then after being listed and receiving an organ transplant, and then some outcomes after lung transplantation. So how do people do once this procedure has been done? So you've heard from Dr. Kolb earlier in great detail about interstitial lung disease and progressive fibrosing interstitial lung disease. But in very basic terms, it's a disease that affects the scaffold of the lung and can be either related to known or unknown causes. And it causes problems because it makes the lungs become more stiff and leads to poor gas exchange. You can see in this basic cartoon at the bottom in panel A is the normal airspace where gases move across to our bloodstream from the airspace. And as fibrosis occurs, this space becomes more thick and makes this process much more difficult, which then leads to low oxygen levels, shortness of breath, and difficulty getting around. The treatment of interstitial lung disease is multifactorial and it takes many approaches, but again, in basic terms, we always recommend quitting smoking if that's an ongoing issue, the use of pulmonary rehabilitation and supplemental oxygen, of course, being up to date on all appropriate vaccines, the identification and treatment of acid reflux if present, and of course, as Dr. Kolb talked about, the evolving landscape of anti-fibrotic drugs in the treatment of both IPF and non-IPF, or the use of immunomodulatory drugs for diseases with inflammation as a major pathogenic factor. Of course, we are always actively involved in research studies and clinical trials. Unfortunately, less so in the time of COVID, but I think we're all looking towards the horizon when all of this is behind us. And you can see on the bottom then, of course, lung transplant is an important consideration in the management of end-stage interstitial lung disease. So looking backwards in time, lung transplant really dates back even before 1963. There was great interest in replacing all sorts of organs, but the first human lung transplantation was attempted in 1963 by Dr. Hardy, you can see here, in Mississippi. Unfortunately, the donor died fairly shortly after the procedure, but he was transplanted for some issues with his left lung and received a single lung transplant at that time. But really, it was a proof of concept that the surgery was possible and that someone could get through and out of the operating room, and sort of promoted a lot of interest in advancing our understanding. There was a lot of technical developments and improvement in surgical understanding and how the procedure was done, and what kind of immunosuppression or drugs that we use to modulate the immune system should be used, particularly around the time of surgery. And I'm going to be speaking a lot about the University of Toronto program today, which is where I have a lot of personal experience and where a lot of these advancements in the technique were done. I know I'm speaking to quite a diverse audience, so I think, again, a lot of these general principles will apply, but I will be presenting some local data as well. In this picture here is a group of surgeons from the University of Toronto from the 1980s. And you can see in the middle there is Dr. Cooper, who really was a pioneer in lung transplant surgery. And the first successful single lung transplant was performed in 1983 to a patient with pulmonary fibrosis who had a reasonably successful sort of survival after the procedure. The first double lung transplant, or where both lungs were replaced, were performed in 1986. And really our understanding and performance of lung transplants has advanced significantly since that time. Dr. Shaf Kashavji, who's the surgeon-in-chief at the University of Toronto and the surgical lead of the transplant program there, has been a major driver of innovation in lung transplantation. He helped develop lead development of a new lung transport solution after the lungs are secured from a donor, and the development of something called ex vivo lung perfusion in 2008, which I'm showing in a picture here. This is a fascinating technology that allows donor lungs to be placed on essentially a circuit in the operating room in this enclosed space, as you can see. It allows for very advanced measurement of different properties to assess the quality of the lungs and actually allow for some lung repair before being transplanted. And this has significantly increased our access to donor lungs by allowing for assessment and sometimes use of lungs that would have been considered unacceptable for transplant in the past. So not only has this increased accessibility of organs, but it's served as a powerful research platform for further innovation. There's two pictures you can see here, and these are courtesy of Dr. Saipel, who was a lead researcher in this study that I'll mention. You can see that this is the ex vivo lung perfusion circuit on the left, and you can see this little box with a bright light coming in the middle here, and this is actually ultraviolet C light that's being beamed into the fluid that's being flushed through these lungs. And this study was focusing on using donors who had hepatitis C, who were found to have hepatitis C at the time where they were determined to be organ donors. In the past, this would have been a major concern for giving someone organs from a patient with hepatitis C. But with the use of antiretroviral medications and this UVC light, there's been excellent success in using these organs in patients who need a transplantation. So these are just examples of some innovation in the field that have increased access to lungs in places where we wouldn't have had access before. So moving specifically to transplant for interstitial lung disease, IPF, it's the second most reason for lung transplant, and it's tied for the most common reason in the Toronto lung transplant program. Although this is probably not true currently, IPF is one of the groups that has improved survival after lung transplant in comparison to patients who receive transplants for COPD or chronic obstructive pulmonary disease. Moving forwards, this is just to show you a couple of things about how the number of procedures we've done over time has rapidly increased. And apologies for all the colors. This data is from the International Society of Heart and Lung Transplant, who have a very large registry and collect information from programs all around the world. You can see that beginning in 1990 and moving along to 2017, the number of transplants around the world in centers who are recording this data has drastically increased. But not only that, the indication for transplant has remarkably changed as well. I've put a little box here on the right to show that those patients with interstitial pneumonia, which is another term for ILD, so either IPF or non-IPF, has grown to become a significant percentage of those patients that we select for transplantation. So interstitial lung disease, as we recognize and diagnose it more often and diagnose people earlier, has become a major indication for transplant. So this is just similar data, just with numbers from the ISHLT. And you can see that in 1988, 69 transplants around the world were done. And in as recent as 2017, there were 4,500. This mirrors our local data at the Toronto Lung Transplant Program. You can see at the beginnings in 1983, 1984, very, very few were being done. And this has grown remarkably over time. You can see in 2019, I believe it was 204, either single or double lung transplants were completed in the Toronto program. Of course, the landscape has changed dramatically this year, which I'll speak to a little bit later. Numbers have obviously significantly decreased for many reasons, but the overall infrastructure remains in place to continue to increase our capacity. So when thinking about lung transplant, who's considered a good candidate? It's a very fine balance. We need someone to be sick enough, so someone with very advanced disease and severe symptoms with functional impairment, and also someone who would be able to benefit from the procedure. Someone without any other major disease and the potential to rehabilitate both before and after the planned transplant. We need to be able to optimize someone for surgery. And by that, I mean, there needs to be no smoking within 6 months of the planned procedure, and to be in an optimal weight or a healthy weight, ideally with a BMI between 18 and 30. As I'll discuss, there's a lot of requirements that take place both before and after transplant. And there's a need to take a number of medications, attend a number of clinic visits, and to have a very strong social support network to support you through this very challenging time. So to get a little bit more into the weeds, when do we consider transplant in patients we're seeing with ILD or IPF in clinic? It's those patients with severely abnormal pulmonary function tests. There are some guidelines out there with specific criteria and cutoff, but it's individualized to every patient that you see. Those patients who you're seeing in clinic over time with worsening pulmonary function tests, so things like the FVC or DLCO are declining, if someone's need for supplemental oxygen is increasing, if someone's developed pulmonary hypertension, which can be a secondary marker that your lung disease is getting worse, or if you have severe disability due to your lung disease. And by that I mean a decreased ability to exercise, get around, or do your tasks of daily life. So there's 4 big questions I think that come up around the issue of lung transplant. The first is, why is it such a big deal? What is a lung transplant assessment? What does it mean to be listed? And what will my life look like after I receive my new lungs? Well, it's a big deal for a few reasons. One is that, as you can imagine, getting donor lungs is a difficult thing to do, and there's not enough lungs to go around for everyone. And so it becomes a resource management issue and trying to provide the greatest benefit to those who need it the most. Lung transplant places a heavy demand on patients and their families, and we'll go through some of the requirements and the process of the transplant that may make that a little bit more clear. Also, lung transplants eventually stop working. Unfortunately, while technically it's curative for your underlying problem, we often run into many issues in the post-transplant period that limit the function of the transplanted lungs. And as I said, we'll talk about that in a little bit more detail. We like to think of it as a trade. So you're trading, of course, a very debilitating and difficult disease in pulmonary fibrosis for a different condition, a lung transplant, which requires a lot of management and support. But of course, we have a very large team who are available to support you through this time. So the next question, what's a lung transplant assessment? Well, essentially it involves, once you've been seen by your referring respirologist and the decision is made to consider this as a possibility, we recommend you go for an assessment, which involves extensive testing. And that's done in collaboration between your referring doctor and the transplant center, wherever you may live. It involves an evaluation of your overall health, so your heart, your lungs, your kidneys. Blood work is done, various scans and other tests to make sure we have up-to-date information to understand you as a person on the whole. And it's not only tests. As I mentioned, there's a very large team that goes into supporting a transplant program. We have occupational therapists, physiotherapists, dietitians, social workers, nurse coordinators, surgeons, anesthetists, respirologists. There's a very large list of people who are all involved in this very complex process. And by meeting all these people, you start to learn about what it means to have a transplant and the various components that go into both preparing for and having success after it being done. So you get to learn about us and we get to learn about you, not only about your health, but who you are as a person, who your family is, who your friends are, where you live, how far away from a transplant center you are, what do you use for transportation. These are all questions that come up as part of the assessment process. And we try and build it as a complete picture as possible of you as a person and your health to help make the most informed decision about whether transplant would be a viable option. Once we've collected all this information, we move on to a multidisciplinary discussion, which involves every member of this team. We sit down together in a room and discuss all of our findings from the assessment, and we put these all together to make a decision on whether or not we should offer a transplant as a reasonable option for management of your interstitial lung disease. If no major problems are identified, then patients can be listed within a few weeks of the meeting. Often we do identify issues that need some correction. So whether there's a heart issue that needs to be addressed, your weight needs to be adjusted, or maybe we need you to work on your 6-minute walk test a little bit. Very often we come back with some ideas or some suggestions of things that may need to be addressed to come back to the assessment meeting again to determine if it's a yes or a no. So you've gone through the assessment process and we'll say, yes, we're ready to go ahead. What does it mean to be put on the list for transplant? So there's a few requirements that must be satisfied. So you must live within close proximity to the hospital. It's a very complicated network of things that happen once a possible donor lungs are identified. And as you can imagine, time is of the essence. So we need our recipients to be within close proximity to the hospital. And by that we mean, at least in our program here, about 2.5 hours. We do see patients from further away, and those people have to move much closer to the hospital and have to rent an apartment. Of course, you must stay as healthy as possible within the limitations of your underlying disease, of course, but understandably, no smoking is allowed, and we do require ongoing participation in a rehabilitation program at least 3 times a week before being listed. Traditionally, this was done in a rehab program on site, but this has evolved a little bit because of the COVID-19 pandemic, which I'll speak to a little bit at the end. Of course, you must wear a pager or have a phone on you at all times because you have to know when you're going to get the call. And of course, when that goes off, you have to be able to present yourself very quickly. A common question is, how long will I wait once I get listed for transplant? And unfortunately, the answer is not very simple. The wait times can range. As you can see, it's very wide, from 2 days up to 2 years. I can tell you that at least in the Toronto program, our average wait time is about 2 to 3 months, and that's current as of the end of 2019. It's a very complicated process that's involved in determining who's on the list and the level of priority. And that all depends on the severity of someone's illness and, of course, how good of a match you are for potential donor lungs. There's a certain number of variables that go into that equation. Things like your blood type. We test for various types of antibodies in your blood. And then, of course, what donor organs become available. And it's a constantly moving target. So it's very difficult to give a specific answer. But of course, we frequently assess people once they're on the list to determine how they're doing and can adjust their status or their priority for transplant if things are getting worse.
Excuse me, Dr. Scallon.
Yes.
Someone wanted to know if they should try to get on the transplant list even if they don't need one right now, given the wait time.
Sure. You know what? I think I'll be able to answer that question with my next few slides because I have a schematic of what the process looks like and how once you've been assessed once you've been integrated into the program, how things will look. So maybe I can answer that with this sort of.
Okay, thank you.
Yeah, no problem. So I think this should answer. It's a waiting or how to approach this. So the referral will come from your respirologist, the person who's managing your care for your interstitial lung disease. It's a discussion between you and them whether or not a referral to the transplant program should be initiated. The general recommendations from our professional societies and from transplant programs would be that early referral for interstitial lung disease is recommended because, as Dr. Kolb alluded to, the trajectory of ILD can be very unpredictable. Things like acute exacerbations can lead to a rapid decline in lung function and a sudden change in health. And so we strongly advocate for getting to know people sooner rather than later to better understand their underlying health and, of course, everything else that's required. So we have a good handle in case things do change quickly. So I'm an advocate for early referral to transplant, to meet with a specific transplant respirologist. So once you've initiated a referral from your caring physician, you'll meet with a transplant respirologist. So someone who deals with transplant specifically and can do an assessment and meet with you and discuss in basic and specific terms about what it means to go through transplant. Based on the outcome of that visit, if it's determined that it's reasonable to go through with an assessment, then that will proceed. And that takes a few months to arrange and perform the tests. Sometimes when you meet with the respirologist, it's determined that you're too early, but you become part of that transplant respirologist network of patients. And so you'll have periodic check-ins to determine how you're doing, how your lung disease is doing, your lung function tests, and then that assessment process can be triggered at any time it's deemed necessary. If you do go through the assessment, you then go to the assessment meeting that I mentioned, and the decision is made as to whether you're suitable or not suitable for transplant. If you're considered suitable but still too healthy, and by that we mean your lung function is still too good, you're still having a reasonable quality of life, then we'll integrate you back into our network of follow-up with your transplant respirologist with periodic assessments to determine how your health is doing. And of course, if there's any change in that time, we can reassess priority and get you onto the next step of the cycle, which would be listing for transplant, as I mentioned before. The determination from being considered suitable to listing can take a few weeks once all the paperwork is filed. And then it's a matter of waiting until you get your new lungs. As I alluded to previously, there's a very wide range of wait times with a very complex number of variables that are involved. But of course, there's continuous assessment during this period to monitor your health and adjust the priority as necessary. So hopefully that answers your question. So on to the next phase. Let's say your pager goes off, you're called into the hospital, and the surgery proceeds. What's life like with new lungs? And we're going to go through the good, the bad, and the ugly. So what are the expectations? Generally speaking, on average, patients are usually in the hospital for about 2 weeks after their surgery, and most patients no longer need oxygen when they leave the hospital. There'll be a lot of things to get used to, muscle strength, recovering from having major chest surgery, of course, with pain and getting normal feeling back. But in 3 to 6 months, we truly hope to have you back in your own home for those who have had to move and back to living as normal a life as possible. We say it takes about 6 to 12 months to truly achieve the maximum lung function from your transplanted lungs, but we really anticipate that people are back at home, really quite independent at about 3 months after their procedure. Some of the challenges, life will never be the same, but we're talking to people who have been dealing with chronic disease for their whole life with severe impairment in quality of life. And so really, some of these challenges are really a reflection of what's been undertaken to improve quality of life and of course, potentially survival. Immediately after transplant, there's a lot of clinic appointments, which can place a big demand on both you as the patient and your family and support network. Once your transplant is finished and you're discharged from the hospital, you have to attend essentially weekly for frequent checkups and assessment. There's lots of testing. So we do blood work initially weekly, which then decreases to about monthly or so. And we do frequent bronchoscopies, which we look for rejection of your new lungs and or possibly infection. And you're on a lot of medications. Many of you will be used to taking medication for your lung disease already, but we use 3 different immunosuppressive medications, which you'll be on for the rest of your life. These medications have side effects, which are significant, and we're always very upfront about the potential for these. Not everyone experiences these, but they're all possible, and so we like to make sure that everyone's aware. There's a high risk of chronic kidney disease. So one of the medications that we use affects the kidneys, which can accumulate over a period of time. And at around 5 years post-transplant, around 10% of our patients unfortunately need dialysis as a result of this. You can end up with having high blood pressure or cholesterol, diabetes, and because your immune system is suppressed, you're at increased risk for infections. Additionally, your risk of cancer is increased because of the use of immune suppressive medications. And so we recommend that patients have regular surveillance for skin cancers, which are remarkably increased, and of course the regular cancer screening as well. And then there's this phenomenon known as chronic graft dysfunction, or as it's sometimes known now as bronchiolitis obliterans syndrome, which means eventually the lungs don't work as well. I've included a graph here from the ISHLT, which shows the progression of bronchiolitis obliterans over time. And this is in all recipients in our registry from lung transplant. And you can see the blue line here is those who've had their first lung transplant done. Perhaps just ignore that orange curve for now, but you can see at 5 years, half of people will have some degree of chronic rejection. And you can see that invariably as time progresses, you're almost guaranteed to have it in at least some degree. Excuse me. So what to expect? How long can I expect to live after I get a lung transplant? I can tell you that 1 year survival is over 90%, and median survival is 5 to 7 years. As you get older, when you go to transplant, your survival does decrease. And we know that in patients over 65, the expected median survival is about 3 to 4 years. I've represented this in a graph here. Of course, there's a lot of different variables that go into calculating these expected outcomes. Depending on whether you get a bilateral, so double or single lung transplant is quite a complex question, but also what other health issues you have and what age you are at time of transplant. But you can see the dotted curve are for those patients who have a double lung transplant done, and the expected outcomes are about 50% of people are alive at 7 to 8 years or so. And for those with single, it's closer to 5. Despite all the risks, for the right patient at the right time, I truly think lung transplant can be considered a miracle. And as I've said, it's a fine balance, and this is why we follow people up very closely. We want to do the right thing at the right time, and of course make sure that we're selecting the best possible people in the best possible shape to go through what's a major procedure with a potentially remarkable outcome. It's not just about survival and who lives longer, but do people feel better? This is again from the ISHLT, and I apologize about it. Look, it's a very busy slide, but basically this shows over the first 3 years what kind of quality of life people have. And the red, blue, green, and purple are those people who are basically able to carry on normal activity, back to normal functioning in life. And you can see that year one, about 60% of people are back to normal function. And that actually increases. So as the years go on, more and more people are being able to get back to doing what they wanted to do. All these things, chasing grandkids around or getting back to work or playing golf, all these things that you miss out on because of your dyspnea and hypoxia, you can restore those functions again. I'd be remiss if I didn't mention COVID-19, given our current climate and the impact of COVID-19 on lung transplantation. There's been some data about how post-lung transplant patients have done with COVID-19. There's obviously concern about taking immune suppressing drugs and being immunocompromised and your outcomes. We don't really have any robust data to say, but we do think that understandably these patients are at increased risk of severe infection. But that being said, there's been no clear signal in the data to date that that's the case. How has it affected the number of transplants that we do? Well, of course, we've had decreased lung transplant activity because of our inability to travel to recover donor lungs. We have teams that go to recover donor lungs from donors who fly all over the place. And you can imagine that's not very easy to do with a lot of the restrictions that have been in place. We've had limited access to critical care beds because of need for patients who are critically unwell. And of course, overall pressure on the healthcare system to create space for patients with COVID-19. And of course, limited access to in-clinic patient visits because of social distancing requirements as well. I think there are some silver linings. Many appointments have been moved to a virtual or remote setting, which I think has had some benefits. It's very difficult to get around when you're hauling around oxygen. And so being able to do some of these remotely, while we can't replace in-person visits altogether, I think this will really complement our armamentarium of caring for patients in a very positive way. Additionally, virtual pulmonary rehab has become very common. In the Toronto lung transplant program, we've been using virtual rehab visits for our patients. So there's no longer a requirement to come into Toronto to do your rehab 3 times a week. So to conclude, since the time of inception of human lung transplant, there's been a huge amount of innovation and new technology, and our outcomes continue to improve. And I think the horizon is very bright for further research, increased access to organs, and improved outcomes for our patients. I hope I've implied that lung transplant is complex and resource intensive, but it truly has the potential to produce excellent outcomes in those patients who we select carefully. And to that effect, determining the correct candidate is essential to give a chance of a good outcome, and education and understanding is integral to that process. So I hope we can lay some basic foundations today, but having further discussions with your respirologist and perhaps a transplant respirologist, I think will be extremely important to better understanding this process in a detailed way. And finally, life without transplant is not without challenges, but does offer improved survival, as we've shown, and markedly increases quality of life. I'd like to say thank you to Dr. Shane Shapiro and Dr. Matthew Binney, who were critical in helping put together this presentation on somewhat short notice. So thank you to them for both their support in the past and for this. And with that, I'd be happy to take any questions. This is my son, Rory. I think corn is the only vegetable I've convinced him to eat, but he does with gusto. So we're going to keep that going.
Thank you very much, Dr. Scallon. And I want to say thank you to Dr. Shane Shapiro and Dr. Matthew Binney, because I've met them both and they're both very generous in their support. And I have to say that I've learned a lot from your slides and presentation, and it's been really, really great. Our first question for you is, could you elaborate more on the antibody levels and availability of donor lungs?
Sure. That's a sort of a two-parter question. So I'll address the first one. When we talk about antibody levels, what I mean is that we measure your blood for these specific types of antibodies that you have in your body. So we all recognize, we all have an immune system that helps us fight off infection or things in our bodies that shouldn't be there. And we recognize other things as foreign. So it's sort of foreign body or foreign antigen recognition. We all have particular patterns of these antibodies in our blood that we're born with that are inherited. And so we do a blood test to test for these antibodies. And what it helps us do is find the best matched donor lungs for you. This goes into various other things, blood type, of course, and then, of course, the size of the lungs. We have to try and match the size of a donor lung to the size of your chest cavity or your thorax. And so it's very important to do, and we do it for every patient who's considered for lung transplant. And while it can have some effect on your wait time, if it takes a little bit longer to find a good match for you, it's a critical part of the process to make sure that you don't have rejection to the transplanted lungs, or we minimize the risk of that happening. Second part of your question was the availability of donor lungs. Of course, this you can talk about on many different levels, from public policy to individual choice. We all have the option to become organ donors when we renew our driver's license, and you can check that box, yes or no. I think this could be a discussion in and of itself. There's many different countries around the world who have different approaches to how organ donor consent is done. So whether it be implied or you have to explicitly give consent. But I think there's a lot of groups doing excellent advocacy work to make people aware of the power of organ donation. There are sort of a lot of factors that affect when organs become available. So whether or not someone has chosen to be an organ donor, and in the manner of how they've passed away. There's people who die because of heart reasons, which, as you can imagine, can have some effect on the lungs. There's some limitations into what organs are suitable for transplant or not. That being said, as I mentioned at the beginning, with the advent of some new technology, we've gained an increased ability to not only better assess lungs for potential transplant, but also to provide some platform to repair lungs that wouldn't have been suitable for transplant before. This is still a growing technology, but has really increased our access to donor lungs. And really that's what it's all about. As I said, it's a limited resource. And if we can increase our access to those, we'll provide this opportunity for many more people.
Could you tell us which hospitals in Canada perform lung transplants? Is there a website that people can look this up?
There is. So most provinces have their own transplant society. So in Ontario, it's like Trillium or Gift of Life. And so they have very comprehensive, not only for lung, but for all solid organ transplant, will have a lot of excellent detailed information, and then information about where programs are and sort of the contact process. Of course, I would strongly recommend going through your respirologist to make a referral. I think that's an essential step. But if you are looking for information, I would just put into Google to look for your provincial organ donation society or organization. I think that's an excellent place to find good resources about this for programs and many other things as well.
Are the criteria for a lung transplant the same at every hospital across Canada, or are there some differences?
There are some differences across programs. I can't speak specifically to any others. I've only worked at the program at the University of Toronto. And what I will say is that our criteria have evolved over time. I think now we're transplanting people at older ages than we were in the past. I think age is a fairly relative concept. It depends on various other factors as well. So I will say that there are some hard and fast criteria that many programs will follow, but it's a very individualized approach depending on where you are. Many of you, if you've done some reading, may have heard about the lung allocation score, which is very often used in the United States to determine who receives lungs and in what priority. Certainly in Toronto, we don't use that, but we use a multi-factor, so a multivariable approach to determining A, who's acceptable for transplant, and B, what priority they should be. So sorry, it's a long answer to a short question, but essentially there are some differences across programs, but there are sort of a core set of values that we all apply.
Okay, thank you. And are you at a disadvantage if you don't live in the provinces that these hospitals perform at?
I'll say yes and no. Yes, in the sense that, of course, you have some geographic restrictions where your life and your home and your family probably are in one place, and the opportunity to receive a transplant is in another. But you're certainly not excluded from transplant by any means by living in a place like that. I would suggest a referral to the nearest transplant center to where you live. And we have a lot of infrastructure in place to help facilitate moving if that's deemed necessary. For example, in Toronto, we see a lot of patients from out east, from Nova Scotia and the other maritime provinces. Patients who move to Toronto, which is not a small undertaking, as you can imagine, to go through the process. And once they've recovered, they can go back home again and then come back periodically for their follow-ups. So I would say disadvantage in the sense that you'll need to take on a lot more responsibility in terms of moving and a lot of the financial and personal hardship that may incur. But there are support programs in place to help you through that process, and people involved in transplant programs who can help you do that as well.
Great. Someone was wondering if you can repeat what percentage will need post-transplant will need dialysis.
Sure. So the rough statistics that I have are around 10% at 5 years. I don't believe that comes from the ISHLT. I don't have that data in front of me at the moment, but there is a significant number, and we see a far larger percentage who do experience some degree of renal dysfunction. So the specific medication that I'm mentioning there, it's called calcineurin inhibitors, and there's two different drugs, either cyclosporin or tacrolimus or tacrolimus. And those have been used for a very long time in all solid organ transplant, most I should say, and they're a cornerstone of our management of solid organ transplant, lungs in particular. For lung transplant, we use much higher doses of immunosuppressive medications than many other organs, which is why we see a lot of these side effects. The rates of rejection or that allograft dysfunction or the obliterans that I mentioned previously is much higher in lungs than other organs. There's many reasons for that, but one is because, of course, the lungs are exposed to the environment. We breathe air in and out multiple times a day. And so the lungs are very vulnerable to very small injuries over time. And so we have to use very high levels of immune suppression. We decrease that amount as we move on. So when you first receive your transplant, you're on very high doses and they do decrease over time. But again, that risk of significant kidney dysfunction does exist. I apologize, I don't have the raw data in front of me, but I can certainly look that up and send that on for review at a later time.
Great. Another question I have for you is how likely would a patient with scleroderma have disease progression in their transplanted lungs?
Okay, so I think the question is about getting their previous disease back in their transplanted lung? Mm-hmm. Okay.
Well, they still have scleroderma, but they got lung transplants, right? Because they have scarring of the lungs. So how would that progress? How would the disease progress?
Getting a lung transplant, of course, doesn't take scleroderma away. I will say that getting recurrence of ILD in your transplanted lung is extremely rare. There's only a handful of case reports that exist in the literature. It's better established for some diseases than others. And there's been, I think, 1 or 2 reports in scleroderma, but very, very few. As you know, with scleroderma, one of the key managements is suppressing the immune system with things like mycophenolate or other medications, which are part of the post-transplant medication regimen. And so while it is theoretically possible, it's extremely rare. And so we don't really consider it as a major problem, but of course, something we always keep in mind if there are problems with the transplanted lung after the procedure.
Okay. Another question for you is, where do your lungs come from? Do they only come in Canada or only in Ontario, or can they come from anywhere, the donation?
Yeah, that's a really great question. So again, that's very center dependent on what transplant center you're talking about. The University of Toronto has a very wide reach for procuring lungs, which are potential for transplant. The majority, as you can imagine, come from the local region, so from the sort of southern, southwestern, central Ontario region. But they do have a couple of planes that are attached to the program, and they will go to the US for some organs or different provinces which are nearby as well. So we do have quite a wide reach. And again, this is very dependent on where in the world or what country or what province you're talking about. A lot of it is logistics. So how quickly can you get to where you need to get the lungs and how quickly can you get back? But again, with the advent of ex vivo lung perfusion, and these new perfusate solutions for instilling in these donor lungs, we've increased the amount of time we're able to keep them between the donor and the recipient.
We have another question. How is it determined that you only get one lung transplant versus a double lung transplant?
Yeah, that's a great question and a very common one. And really what I think prompts that question is looking at those curves that I showed before. I might go back because this does really bring up a lot of questions. There are certain conditions where a double lung transplant is the only option. So people who have serious lung infections, this is more common in our patients with something like cystic fibrosis. But if you do have sort of chronic lung infections of a certain type, unfortunately only a double lung transplant is possible. If you have significant pulmonary hypertension or high pressures around the lungs and the heart, then a double lung transplant is generally the only option for you. But for many patients with IPF or ILD in general, a single lung transplant is an option. There are a couple of advantages to it. It's a shorter, faster operation, and generally speaking, recovery may be a little bit faster. And as you can imagine, if you're getting 2 lungs from a donor and you're planning to do 2 single transplants, you've doubled the amount of organs that are available for potential recipients. What we often do, generally speaking, a double lung transplant will give you higher lung function because, as you can imagine, with a single, you're leaving a native lung behind that still has disease. But our lungs have massive capacity beyond what we need for function in day-to-day life. So with a single transplanted lung, we still expect that you can get off oxygen and recover almost a completely normal quality of life. That being said, there may be a slightly decreased survival with a single lung transplant. And this graph really isn't fair because these are unadjusted numbers. So these are raw data for all recipients of either bilateral or a single. We tend to skew a little bit towards single lung transplant in older patients. And so that does skew the survival curve a little bit. But really when you adjust the numbers and do robust assessment of this, the relative difference is actually quite small. So it's really a multifaceted conversation in the sense of how many lungs are available to different individuals, what the relative difference in mortality is. What we'll usually do is if you're a candidate for a single lung transplant in Toronto, we'll list you for both. And whichever lungs we can get you more quickly, then that's the procedure we'll proceed with. Unless something, of course, changes in the interim and you're only a candidate for a double lung transplant. So it's a bit of a complicated question and sort of requires considering multiple factors. But again, I think really what we want to avoid is people missing out on their chance or passing away while on the wait list. So I think a lot of the priority is to get the procedure done really as quickly as possible once the person's considered a candidate for transplant.
The next question is, how long do the lungs last before being transplanted?
I'm not sure I fully understand that question.
I guess, when a lung is donated, how long do you have before it's not viable anymore for a transplant?
Okay, yeah, no, sorry, apologies. That's an excellent question. So that's, again, a little bit of a complicated answer because it depends on the condition of the lungs when they're procured and whether or not the decision is used to put them on ex vivo lung perfusion, which is that fancy little machine I showed you at the beginning. I'm not a transplant surgeon by any means, so my understanding of this is limited to working with these patients in the program. But generally speaking, it's on the order of hours. So I think around 8 to 12 or 16 hours, depending on whether or not EVLP is decided to be used or not. So as you can imagine, time is of the essence when this happens. And so it's a very complex coordinated effort to send out the team who's going to retrieve the donor lungs, to contact the patient, to be in for assessment and preparation for surgery in very rapid time. It is a very involved and very fast-moving process.
Okay, great. Dr. Scala, another question that someone had is, if you already had a lung transplant and for a couple of years, but then they're failing, are you eligible for another lung transplant?
Yeah, that's another really good question. And again, it's a little bit complex and would require discussion with your transplant team. I will say, I showed you a curve before, which I can go back to again, that there are a large number of retransplants done. So you can see here the curve of this bronchiolitis obliterans or chronic rejection. So there are a significant amount of retransplants done. It all depends on what the context of your lung problems are, what other medical issues you have, what age you are, of course. So it involves a very careful discussion with your transplant team, and it's a very individual decision. I will say that, as you can see here, the risk of rejection is much higher when you receive a retransplant. As you can imagine, your body's very sensitized to foreign tissue at that point in time. But again, it is a consideration, but it requires a careful discussion with your transplant team.
Okay. Someone wanted to go back to the answer you had previously. Are there stats to actually say how well a patient who receives a single lung versus a double lung? The native lung continues to fibrose and shrink and interferes with oxygen perfusion of the blood during exertion.
Mm-hmm. Yeah, excellent question. So practically speaking, I can say that most often, the native lung does not cause a huge amount of problems. Unfortunately, some patients will still have some degree of cough that persists. But again, actually, that seems to improve significantly. And our bodies have a fascinating ability to move blood away from areas that aren't working very well in the lungs. It's a process called shunting. So let's say you have a donor lung and a native lung. The native lung has a lot of scar and fibrosis and is really not oxygenating your blood very well. Your lungs will intelligently shunt blood in the direction of your new lung to preferentially perfuse that area that's oxygenating well. And so we really see, even with single lung transplants, oxygen saturations remain excellent. And while the fibrosis remains and does progress over time, really people have a very high quality of life and high level of function without hypoxic respiratory failure. Now, again, as you've seen, we haven't been doing transplants for hundreds of years, and we're beginning to understand this more and more every day. And so, of course, the role of the native lung and how it's involved in outcomes is still an area that needs further research and understanding. But we know that single lung transplants are successful and provide improved survival and quality of life.
Okay, thank you. There's another question for you. For the lungs, there has been research that shows that they're now accepting lungs with people who might have tuberculosis or some types of cancer in their other body organs or HIV. Are these lungs acceptable for these transplants?
So that's another excellent question. I mentioned at the very beginning the new technology platform looking at donor lungs from hepatitis C positive donors, and that was a major paradigm shift in the approach to using these transplanted organs. I will say that tuberculosis in the donor lung would be a contraindication for transplant. HIV would be a similar concern as well, because we do not have curative treatments which are available for transplanting those lungs. That being said, there are a lot of people exploring expanding our criteria for procurement of lungs that would have been previously considered unacceptable. The major area here would be people who have cardiac arrest, which, as I mentioned before, can cause a lot of damage to lungs. But again, with the advent of ex vivo lung perfusion, we can actually perform some repair and recovery of these lung tissues. So again, that's a bit of a growing area, but as I said, there are some lungs now that would have been considered possible before that are currently.
Great. Are there any further questions for Dr. Scallon at this moment?
I will
sure, go ahead.
I will say that as I mentioned, education and understanding is essential. So I would strongly advocate that everyone visit your local solid organ society or program. Go on their website, because there's a lot of material you can read. Most local programs have their own handbooks or information that are available for patients to go through. Can be often generate a lot of questions. And I always tell the people, if you're thinking about transplant, just create a notebook. So go buy one of those spiral notebooks, and you have to start writing down all your questions, things that come up, because very often you get in the clinic and everything evaporates. You know, you show up and all those amazing questions you had just disappear. So really become a fan of writing things down and recording, you know, questions or thoughts that you might have. I think that's a really useful tip.
Great. Thank you, Dr. Scallon. And I would ask everyone who's on this webinar at the moment to please fill out your survey, because that gives us feedback about this presentation and any other in-depth presentation, as we would love to be able to invite Dr. Scallon to come back and explore some of those other topics for future webinars and perhaps for next year's sessions. Great. Thank you very much, Dr. Scallon. It's been a pleasure to having you on. I've learned so much. I'm sure, as our audience have said as well, that it's been a very informative and fascinating topic, and you've made the topic really easy to digest. So thank you very much.
Thank you. Thanks so much for having me. Take care.
Okay, bye-bye.